Good afternoon, ladies and gentlemen. It's my great pleasure to welcome you again to the webinar organized in a collaboration between the European Reference Kidney Network and the European Society of Pediatric Nephrology. The topic of today is IgA nephropathy and Hinox-Schönlein nephritis, which will be presented by Rosanna COOPO from Turin, Italy. My name is Elena Levchenko. I'm a pediatric nephrologist from Leuven, Belgium, and I will moderate this webinar for you today. Let me introduce our speaker, Rosanna COOPO. Rosanna has a huge contribution in nephrology and pediatric nephrology. She graduated at the University of Turin in Italy, and there was a director of nephrology, dialysis and transplantation in Regina Margherita Children's Hospital in Turin, Italy, and professor of pediatric nephrology at the University of Turin from 1989 to 2015. Rosanna was a Secretary General of the European Society of Pediatric Nephrology and IPNA Council member from 2012 and 2015. She was also coordinating the immunonephrology working group of ERA-EDTA. After her retirement, Rosanna works, I think, even harder than before. So at this moment, she is a scientific co-chair of the IPNA Congress in 2022, and she is a chair for Western Europe of the International Society of Nephrology, ISN. We all know Rosanna for her huge contribution. She was awarded with many awards, among others in 2016 by ERA-EDTA Award for Outstanding Contribution to Nephrology, and in 2020 she became ESPN honorary member. So before giving the floor to Rosanna, I would like to remind you that during the webinar you can ask your questions during the whole presentation by typing them in the question panel, and the questions will be answered at the end of the webinar. I wish you a very good learning experience, and I give a floor to Rosanna. So Rosanna, we are eager to hear your talk, please.
Elena, thank you for this kind of presentation. It doesn't move. Oh, I'm sorry, it doesn't move.
Are you in the presentation mode?
I don't know why it doesn't move.
We can see you, Rosanna. So, but
yeah, but okay, now it's moving. Let's hope it's better. I'm sorry. IgA nephropathy is defined by the detection of immunoglobulin A in glomeruli as dominant or codominant in respect to the other immunoglobulins, and C3 deposits are always present. However, this definition fits with primary IgA nephropathy or Berger disease, as well as IgA vasculitis nephritis, formerly called Hinox-Schönlein purpura nephritis.
So I'm not sure if I'm sorry to interrupt you, because I'm not sure. I see only your camera, but I don't see your slides. But maybe it's only the problem in my computer.
And now I see my slides. You don't?
No,
no.
I don't.
No, we cannot see the slides.
I can see them. I don't know what
maybe
can I do.
Maybe you can try to switch off your camera.
My camera, let me see. My camera is switched off now, but it doesn't move. And that way it doesn't move. It doesn't move. My presentation moves only if there is something wrong. I'm sorry. It doesn't move. And in this way, it doesn't move as well.
And we still see you, so your camera is not switched off?
My camera is switched off now. It's switched off. And I see my first slide, but it doesn't move.
Maybe, I don't know whether you can send your slides. Tanya, do you have slides of Rosanna that you can project the slides and Rosanna can give the lecture?
No, I don't have the slides. Maybe you can send it.
And no, I don't think so.
Now we
Yes.
see your
Now
slides.
It's because it was good. Now, do you see
now
my
it's
screen?
Yes, it's perfect now. Perfect. Okay, perfect. So we can start the lectures. Sorry, everybody, for this technical problem.
Okay. Sorry. So the starting back, IgA nephropathy is defined by the predominant deposition of immunoglobulin A, dominant in respect to other immunoglobulins, with concomitant deposition of C3. But this definition can identify primary IgA nephropathy or Berger disease, as well as IgA nephropathy secondary to vasculitis, I mean Enoch-Schonlein purpura nephropathy. So the first question is, how many patients with primary IgA nephropathy or with IgA vasculitis nephritis, Enoch-Schonlein purpura nephritis, have you seen?
Okay, so maybe Tanya, you can go on.
Okay.
So, Rosanna, the majority, 77%, have seen more than 5 patients, and 19% have seen between 1 and 5.
Okay, good. So let's consider these two entities. Primary IgA nephropathy is characterized by gross hematuria following an upper respiratory tract infection, or by microscopic hematuria with or without associated proteinuria. And it is most common in young adults, in whom it showed a relentless progression. In children, there is a possibility of remission and frequent progression over decades. IgA vasculitis, which was called the Enoch-Schonlein purpura, is a true vasculitis with IgA dominant immune deposits in the small vessels, capillaries, venules, arteries, involving skin, gut, and glomeruli, and associated with arthralgia or arthritis. However, from the point of view of the nephrologic renal features, the diseases are exactly the same. The onset is characterized by palpable purpura and multi-organ system involvement with hematuria and proteinuria. It's most common in children, and in children more frequently the disease went into remission. In rare cases, there is a rapid progression, and in some cases there is progression over decades. So let's consider the first entity, primary IgA nephropathy. This is a rather common glomerular disease among glomerular disease needing renal biopsy. 16% of renal biopsy are indeed IgA nephropathy. And this is particularly frequent in Asia, accounting for 36% of renal biopsy, and in Europe, accounting for 20% of renal biopsy. Less frequent in America and Latin or Northern America. Indeed, there is an eastwards and northwards greater prevalence of IgA nephropathy around the world. But we have to say that the frequency of IgA nephropathy depends on the indication to perform renal biopsy, because renal biopsy is needed. It's the only way to detect this disease. It depends if screening programs are active, or if renal biopsy usually follows the detection of minor urinary abnormalities, or if renal biopsy follow episodes of evident gross hematuria. The incidence in children here varies from 5 to 50 cases per million per person, and is again particularly frequent in Asia in respect to Europe, particularly because there are these screening programs active in the school. The progression is different in children and in adults. In Europe, we performed a very nice collaborative study which gathered more than 1,000 patients with IgA nephropathy of any ages, followed for about 5 years, and we observed, we confirmed a different progression in children than in adults. Indeed, a few children reach end-stage renal disease with need of renal replacement therapy during the pediatric age or as young adults. But considering that 50% of patients needing dialysis enter dialysis before the age of 20 years, it is clear that several progressive IgA nephropathy begin early in the life. So 30–60% of children with IgA nephropathy will never experience a decline in GFR over a longer and happy life. However, 10 years and 20% at 20 years after renal biopsy progress to end-stage renal failure or loss of 50% of GFR. And moreover, in several adult subjects, the diagnosis of IgA nephropathy follows chance-finding investigation for hypertension or reduced GFR. So there is the need to identify children with IgA nephropathy at risk of progression. Genetic factors seem to play a role. Indeed, the study 10 years ago showed 3 areas of SNPs which were significantly different in IgA nephropathy and healthy controls, encoding for HLA, complement, lymphomononuclear cell interplay. But the milestone was a large GVAS study involving more than 20,000 people around the world, led by the Columbia University, Christoph Kirrup, Yanni Gravi, which showed that loci associated with innate immunity against intestinal pathogens were characteristic of patients with IgA nephropathy and play an effect in 5–7% of the disease. Most loci associated with IgA nephropathy are also associated with the risk of inflammatory bowel diseases or the maintenance of the intestinal barrier in response to intestinal pathogens. And there is a particularly high frequency of these risk alleles in 15 loci, which are associated with early manifestation of IgA nephropathy. That means pediatric nephrology. So a genetic background is there, but this accounts only for 5–7% of the variability of IgA nephropathy. Which are the pathogenetic mechanisms for the development of IgA nephropathy? Well, the first point, the most important, is the presence of galactose-deficient IgA1, which lacks galactose, the terminal galactose, or an acetyl-galactosamine, the galactose residues, which are bound to an insertion of amino acid in the hinge region of IgA1. The increased circulation of galactose-deficient IgA1 induces a series of effects, the so-called 4-hit hypothesis. The production of a unique anti-glycan antibody, thus the formation of IgA-containing circulating immune complexes, leading to the 4th hit. So this is the mesangial deposition, the activation of mesangial cells, with the proliferation of mesangial cells, production of extracellular matrix, release of cytokines, growth factors, till the full development of inflammatory renal glomerular disease with IgA1 and C3 deposits. IgA nephropathy has variable clinical features, renal lesions, and outcomes. There's ranging from remission, from an indolent course, slow progression, or rapid progression. In adults, most frequently, IgA nephropathy is a slowly progressive disease. In children, as I mentioned before, it depends from the indication to perform renal biopsy. Since the diseases which are detected by school screening programs or control for sports are detected in the early phase and usually are not really progressive. While in cases of children who went to perform renal biopsy because of history of kidney disease in the family or because previous episodes of gross hematuria, the progression potential is obviously greater, as well, even worse, if the diagnosis is made after the detection of stable change in urine color, edema, fatigue, polyuria, hypertension. Those are late symptoms, and so the progression obviously is worse. But what is of interest is what was reported by the Japanese group on Norisuke Yoshikawa, that they investigated a group of 100 children with minimal urinary glomerular abnormalities and minimal urinary abnormalities as well. But anyway, they went in complete remission, 50% of the cases after 5 years, and even more after 10 years. But the same children had a recurrence of urinary abnormalities in 20% after 5 years and 30% after 10 years. So suggesting that the disease is not stable. you can have phases of clinical activity and phases of remission, which can follow each other during the years. So there is a need of a continuous monitoring. Which are the clinical risk factors for the progression of IgA nephropathy? In adults, they are quite clear, showed by the Mayo Clinic group 20 years ago: proteinuria, hypertension, or radio reduction, renal function at presentation are signs significantly associated with the progressive course of the disease. We investigated in a subgroup analysis the young subjects in our Valiga study, and we observed an effect of the age on the hazard of the combined event of 50% reduction in GFR over stage renal disease. We showed a linear association until the age of 23 years, then a change in the slope. So suggesting that young subjects with IgA nephropathy have the possibility of improvement of the disease, either spontaneous or probably induced by therapy. And of interest from this analysis, we showed in this data were confirmed by others that clinical data, the renal biopsy, proteinuria, hypertension, reduced GFR in children are not significant predictor of outcome because are often associated with acute nephritic syndrome, which can be partially reversible. While what is a real sign of potential progression is the persistence of proteinuria. That means follow-up or time average proteinuria and persistent abnormal blood pressure values. In children followed in our European study for a median of almost 5 years, there was in median a persistent mild proteinuria, 0.5 gram per day, despite treatments. And we observed that also these levels of proteinuria below 1 gram per day, higher than 5 grams, can be a significant risk factor for progression. So our children in the long term are under the effect of possible risk of progression. The renal lesions are very variable in IgA nephropathy, and they were considered to be a risk for progression. The international clinical pathological consensus led to this Oxford classification, which found 4 histological features: mesangial hypercellularity, endocapillary hypercellularity, segmental glomerulosclerosis, tubular atrophy, interstitial fibrosis, which were risk factors for progression, independent from the data at renal biopsy and even during the follow-up. And the value of crescents was showed in a late subsequent study. In our recent reanalysis of long-term follow-up of these 1,000 patients with IgA nephropathy for a median time of 7 years up to 35 years, which we confirmed the value of mesangial hypercellularity, segmental sclerosis, tubular atrophy, interstitial fibrosis, which was independent from the age. That means valid for children as well as for adults. And when we consider the progression of renal function decline, also crescents in patients who never received the corticosteroid immunotherapy treatment were found to be a risk factor for progression, again independent of age, so valid for children as well as for adults. But most of all, it is of interest the combination of clinical and pathology risk factors. Indeed, the Oxford classification showed an improved prognostication when the pathology data, the MEST-C score, were added on the classical clinical variables. And last year, we published this large study, more than 390, about 4,000 patients with IgA nephropathy, gathering various multinational cohorts, which were divided into derivation and validation cohorts, and allowed Sean Barbour from the Vancouver University to set up a tool, a prediction tool. This prediction tool can be available on a mobile app calculator as well as a web-based calculator. and including age, sex, race, GFR, blood pressure, proteinuria, the previous use of renin-angiotensin system or immunosuppression, and the NEST score. The system allows the calculation of the risk of reaching the composite endpoint of 50% decline in GFR or end-stage renal disease after a given period, for instance, 5 years, as you can see in this example. And this prediction of progression at 5 years reflects a mean decline in GFR in the following years and allow the stratification of patients into low risk, intermediate risk, higher risk, higher risk. We recently updated this prediction tool for the use in children, and it is published online. You can find it in PubMed. We will shortly publish on Kid International. 1,000 children were investigated, again from various cohorts, and we observed, first of all, that in adults, the eGFR trajectory was rather linear over the time, while in the pediatric cohort, it was linear after the age of 18, 20 years, but the first part showed a possibility of improvement, which is completely different from the adult cohort. That led to an update of the formula, which is available again on the web, which allow a risk stratification in children with low risk or medium or higher risk of progression, and we set a 30% decline on GFR or a stage renal disease in the final endpoint. That could be of future interest for the future trials. As far as treatments are concerned, let's consider the KDIGO clinical practice guideline for glomerulonephritis, which are about to be published. The first general recommendation are to target blood pressure and proteinuria with renin-angiotensin system inhibitors in subjects with IgA nephropathy. And for children, the goal is to reduce the mean arterial pressure below 50%, according to age and sex, and or the maximally tolerated dose. But even in case without hypertension, the recommendations are to treat with either angiotensin converting enzyme inhibitors or angiotensin blockers if proteinuria is higher than 0.5 in general, but for children is higher than 0.2. For what is concerning corticosteroids, in 2012, KDIGO reported that if proteinuria persisted above 1 gram per day, despite 3-6 months of optimized supportive care, including renin-angiotensin blockade, there was an indication to give a course, a 6-month course of corticosteroid therapy. And the Cochrane database repeatedly stated, also in this very recent Cochrane database systemic review, involved about 60 cases, about 4,000 patients with IgA nephropathy, including 6 randomized trials in children, that corticosteroid therapy may be of benefit in adults as well as in children with IgA nephropathy and proteinuria. However, the value and indication to corticosteroids have received some negative input from the results of a couple of very large recent trials. And the controversy conference held in Singapore a couple of years ago led to this conclusion that the STOP trial showed that the optimized supportive care with renin-angiotensin system inhibitors induced a very slow decline in GFR, while the addition of corticosteroids immunosuppressive therapy induced only a transient reduction in proteinuria over 3 years, but had no impact on GFR. And on the other hand, they pointed out the significant increase in adverse events in the steroids arm. And another very large trial, or again in adults, the testing trial, was discontinued due to the high risk of adverse events in the group receiving methylprednisolone in comparison to the placebo. And there was a significant increase in infection, including unfortunately, to death. And that was a pity because from the initial results, there was a significant protection from the decline of GFR at 40%, but the trial was interrupted because of safety. So the KDIGO 2012 took into account this large trial and led to the assessment that the first point is to try to optimize the supportive care with rigorous blood pressure control and maximally tolerate dose of renin-angiotensin system inhibitors. In adults, they include a series of lifestyle modifications like weight reduction, exercise, smoking cessation, protein restriction, salt restriction, address cardiovascular risk, which only partially can be applied to children. Anyway, the conclusion were very cautious that if the supportive care did not induce a significant proteinuria reduction, corticosteroids for 6 months are recommended after recognition of adverse events and thorough discussion with the patient. What about children? In children, we had this very nice study 20 years ago from the IgA Yoshikawa group. They enrolled only children with very heavy mesangial proliferation, more than 80%. And children were treated with prednisone and azathioprine, in addition or not with anticoagulation and antiplatelet therapy. And after 2 years in corticosteroids, the children showed a reduction in mesangial proliferation, showed a protection from glomerular sclerosis increase, and a strict reduction in proteinuria from 1.2 to 0.2. In 2 cases, there were some severe side effects, and the trial was discontinued. But it was of interest that after 10 years of uncontrolled treatment, the children who had had corticosteroid therapy for 2 years were protected from the renal function decline in comparison to those receiving anticoagulation alone. Over the years, several studies were performed looking at the effect of corticosteroids immunotherapy in children with IgA nephropathy, but the results were almost heterogeneous and inconclusive because most of these studies were very limited in number of cases, and most involved very active cases with nephrotic syndrome or with rapidly progressive disease or with crescentic form. And the true randomized controlled trials, very small and very limited, were indeed negative. KDIGO this year will present some practice points specifically devoted to children. So the first, as I mentioned before, is to treat with renin-angiotensin system inhibition children with proteinuria higher than 200 milligrams per day per 1.73 square meters. But they consider that most pediatric nephrologists will treat children with proteinuria higher than 1 gram and mesangial hypercellularity with corticosteroids in addition to this RAS blockade. And the KDIGO indicates that, as in adults, when children have a rapidly progressive IgA nephropathy, have a poor outcome. And despite the limited evidence, we have to offer these children treatment with corticosteroids, usually methylprednisone pulses, and oral cyclophosphamide. And moreover, there is the need to continue to follow patients even after complete remission, as they can relapse after many years. But there are other therapeutic targets for treatment. For instance, targeting the gut-associated lymphoid tissue. There is a clear gut-kidney axis in IgA nephropathy. I mentioned before the genetic factors investigated showed by the large GBAS study, and other study, particularly in animals and a few in humans, showing the effects on intestinal microbiota and diet. Anyway, there is a clear activation of intestinal immunity in IgA nephropathy with subclinical intestinal mucosa inflammation leading to IgA dysgranulated synthesis. This is why it's particularly of interest the development of a target-released formulation of the glucocorticoid budesonide which allows the delivering of the drug at the ileocecal junction, which is particularly rich in PA patches. The NEFIGAN study reported the use of this target release budesonide treatment in adult patients treated for 9 months, finding a decrease in proteinuria and a maintenance of a good renal function. Other approaches have been tested. Tonsillectomy was mostly discussed and used in Asia. Other mycophenolate mofetil, cyclophosphamide, rituximab, more recently hydroxychloroquine. Others are in the pipeline and ready to be used as anti-endothelin associated with RAS inhibition or inhibitors of the FTNF, TNF receptor family, or anti-complement factors, which are particularly of interest, but the results will be available in the next year. So this is IgA nephropathy. My second question is, are IgA nephropathy and IgA vasculitis nephritis, or shown in purple, the same disease with different expression? Will you make the poll?
Tanya, can you show the poll for voting? Because I don't see the poll. Okay, now you can vote, please. Okay, I think we can close the poll. Okay, so the majority said yes, 69%, and 31% say no.
Okay. Okay, and let's see. IgA vasculitis nephritis, or inoxone purpura nephritis, is a vasculitis, as I mentioned before. And in children, inoxone purpura is the most common vasculitis. The incidence in children is 60-140 cases per million children. The peak age is 6 years. And the involvement of the kidney develops in 20 to 80% of the cases, in median in 30% of the cases. The incidence is much lower in adults, about 10 times lower, but in most of the cases, the involvement of the kidney is evident. In children, in 33%, there is the progression to end-stage renal disease in the long-term follow-up. But in 70-80% of the case, there is a recovery in 4 weeks, so in a short time. Only in 20-28% of the cases, there is persistent urinary sediment for more than 1 month. So the disease is characterized by a frequent rapid regression in children. Today, rarely children with IgA vasculitis nephritis reach kidney failure within the pediatric age, probably because we are more aggressive than in the past for the treatment of the initial phase. However, the disease can progress and the subclinical damage can develop chronic damage, chronic kidney disease, as well as hypertension. From the pathogenetic point of view, the 4-hit hypothesis is considered to be valid in IgA vasculitis nephritis as well as in primary IgA nephropathy. However, the diseases are different, so interest has recently been focused on the factors which may influence the difference: genetics, initial promoting factors, inflammatory mediators. This very nice review reviewed a series of work, in general limited as extent of number of patients, but very deep analysis, which showed a correlation between the presence of HLA class 2 DRB1 and HLA class 1B for the development of IgA vasculitis nephritis, and for the genes encoding for cytokines, chemokines, adhesion molecules, T cells. But what is of interest, they found also an association between genes which in some way are involved with the vascular health. I mean, nitric oxide, neoangiogenesis, renin-angiotensin system, homocysteine. Another point extremely of interest is the genetic influence induced by the genes encoding for IgA galactosylation. IgA galactosylation is, as I mentioned before, the first step in the pathogenesis of IgA nephropathy. So it was of interest to look at the levels of galactose-deficient IgA1 in these various groups of patients. But the results were that the levels of galactose-deficient IgA1 were about the same in IgA nephropathy, in IgA vasculitis nephritis, in children and in adults. Another point of interest was to look at the biomarkers for the development of IgA nephropathy and for the mediators of renal damage to see if the different levels of these biomarkers could identify different patients with different progression. All these biomarkers, which were investigated by the French group of Angeline Philibou, showed increased values in subjects with IgA vasculitis nephritis versus those without nephritis. This was true in adults, as well as the same group investigated the children and found that particularly the levels of IgA, IL-6, IL-8 in the urine in both adults and children were biomarkers valid and univariate analysis to identify patients with renal involvement. However, in multivariate analysis, there was no effect of these biomarkers on disease expression and particularly on progression, which was a pity because the study was very good. So when we reviewed together with Jean-Claude Davin, who is the true expert in the world in IgA vasculitis nephritis, the disease, we consider that the immune reactions involved in the pathogenesis of IgA nephropathy, circulating IgA molecules, receptors, cytokines, messenger cells, and the products of messenger cells were the same in the various studies in IgA, in primary IgA nephropathy and in IgA nephritis, vasculitis, henochonic purpura nephritis. So what can be the factor affecting this different expression? Well, we reason that IgA vasculitis is a vasculitis. So maybe we have to consider the factors which are peculiar for a vasculitis: complement activation, endothelial activation, coagulation, crescent formation. Let's consider these points. Complement activation is particularly evident in serum and in renal tissue in subjects with IgA vasculitis nephritis and henochonic purpura, but also in primary IgA nephropathy. But the activation of the coagulation is strictly more evident in IgA vasculitis nephritis. However, also in primary IgA nephropathy, we have signs of complement activation at renal deposits, allowing the detection of C4d deposits, which indicate a lectin pathway activation, which characterize adult and children with progressive IgA nephropathy. And of interest, the same biomarkers, the presence of C4d deposits, in co-localization with microangiopathic lesions, characterize patients with IgA vasculitis, with henochonic purpura nephritis. And of interest, the presence of microangiopathic lesions as well as deposits of C4d characterize children and adults with progression and loss of renal function. Indeed, the glomerular endothelial activation, C4d deposits, and microangiopathy are relevant in primary IgA nephropathy as well as in IgA vasculitis, but even more in IgA vasculitis. And there, a particular role can be played by IgA directed against endothelial cells. Indeed, under the effect of infection, a release of TNF-alpha can enhance the binding of circulating IgA against the endothelial cells to the vascular surface, and that can be the first actor in promoting the vasculitic lesions. Another point of interest is the presence of crescents, which is typical of vasculitis. And indeed, the International Study of Kidney Disease Classification focused on the presence or absence of crescents. And in case of crescentic lesions, cases were divided according to the presence of crescents in less than 50%, 15, 50, 75, or more than 75% of crescents. And this classification was widely used. In a study 20 years ago, we performed on more than 200 patients, including 83 children, with renal biopsy and IgA vasculitis nephritis. We observed that almost half of the cases did not show crescents, and the other half had crescents in less than 50% of glomeruli. And in these cases, no effect of renal function decline was found, having or not these relatively small amounts of crescents. And this was particularly evident in children, while for adults there was a borderline significance. While looking for the effect on long-term follow-up, the factor which mostly affected the progression was the persistence of proteinuria over the long-term follow-up, exactly as for primary IgA nephropathy. Since in primary IgA nephropathy the Oxford classification was so successful and widely adopted, everybody looked at the possibility to use this classification also for IgA vasculitis nephritis. And this nice meta-analysis showed that in children, mesangial proliferation, endocapillary proliferation, segmental sclerosis, tubular atrophy, interstitial fibrosis were significant predictors of outcomes in majority of the cases. However, no predictive value was found for crescents in children. Why that? Well, because the crescents are found when biopsy is prompt, may be coincident with acute onset, may regress and evolve into sclerotic lesions. So the percentage of crescentic lesions can vary according to the timing of renal biopsy. And this was beautifully shown by this German Society Pediatric Nephrology study, which showed that the cellular and fibrous crescents depend on timing of renal biopsy. And the chronicity indexes influence the negative outcome, while the persistence of low-grade proteinuria correlate with chronic lesions and outcome. And also a recently published study from our Finnish friend, Dr. Kosela, showed a reduction in activity index, and particularly of endocapillary hypercellularity crescentic lesions in children in the second renal biopsy, while the chronicity index increased in the second renal biopsy in children with shown for paranephritis. So IgA vasculitis nephritis is a vasculitis. It is characterized by endocapillary hypercellularity and crescents at the most relevant features. Has an acute onset, a rapid development, a possible regression, but after the acute onset can proceed like primary IgA nephropathy with a slowly progressive course, sometimes with new pousset of activity. So there is a need of the predictive model like that we recently have available for IgA, primary IgA nephropathy, and the study is in progress thanks to the effort of the brilliant pathologist Mark Haas. So the third question is, would you treat a child with Hinox-Shoney purpura IgA vasculitis with prednisone to prevent the development of nephritis?
Okay, Tanya, I think we can close because it's only yes or no. So most of the people said no, 74%, and 26% answered yes.
Okay. The last KDIGO in 2012 had two major points. First of all, we recommend not to use corticosteroid to prevent inoxia purpura. And the second is to use the same treatment in children as in adults with inoxia purpura. Almost 10 years later, the recommendation remained the same for not using corticosteroid to prevent nephritis in patients with isolated IgA vasculitis. And this was tested by a very nice study from Jan Tizard in the UK. While for what is concerning the treatment in general, the KDIGO took advantage of this large European consensus-based recommendation for treatment of IgA vasculitis, the SHARE initiative, which considered mild, moderate, severe forms of IgA vasculitis nephritis according to the level of proteinuria below 2020 and according to the presence of crescents, again, less and more than 50%. And this study was considered, this report, and in the next KDIGO issue, the practice point for the management of children with IgA nephropathy has changed, and so there are some differences in comparison to the adults. There is the consideration that children above 10 years of age more often present with non-nephrotic range proteinuria, impaired kidney function, and may suffer more chronic histological lesions with delay of biopsy longer than 30 years. So there is a fear of delay of treatment because this is harmful. Children with persistent proteinuria for more than 3 months should be treated with renin-angiotensin system blockade, and the pediatric nephrology should be consulted. But what is different is to use, in case of mild or moderate IgA vasculitis nephritis, a cycle of 2-3 weeks of oral prednisone or pulsed intravenous methylprednisolone. While in children with IgA vasculitis with nephrotic syndrome or rapidly deteriorated kidney function, the treatment should be prompt and aggressive, as for rapidly progressive IgA nephritis or for ANCA vasculitis with methylprednisolone pulses and cyclophosphamide. However, this is an expert opinion only, based on indication of a set of excellent experts, but only their opinion was used because the number of hard trials is very limited, and the lower threshold of proteinuria for treated and not treated patients is not indicated. There are several other treatment options for IgA nephropathy, but the results are very scanty, and they wait for a new risk stratification. Before going to the question and answer, I would like to introduce the next webinars, as you can see from this slide, from Nicole van der Kar, OSTEC and associated hemolytic uremic syndrome, Michael Somers, acute post-streptococcal glomerulonephritis, and Sadino Shashan from TMA and antiphospholipoid syndrome. Thank you for your attention.
Thank you very much, Rosanna, for this really brilliant presentation. You covered so many aspects in this lecture, really wonderful. We have a lot of questions, so we'll try to answer at least some of them because the list is full. One question is from Dr. Yokshin Yap, whether the IgA nephropathy prediction tool can be also used in children.
Yes, the tool which was published in 2019 in JAMA was could be used only for adult subjects. But now this new prediction tool, which is available in PubMed and will be shortly published in Kidney International, but the text is available as a formula, a new formula, which is an updating of the old formula, which will consider not 50% decline on GFR or end-stage renal disease as a final endpoint, but 30% reduction in GFR and end-stage renal disease. And it was modified in this way because the number of endpoints when we consider children with IgA nephropathy is so limited that we should have a very long follow-up to get a sufficient number. And so we took 30% reduction in GFR, and Sean Barbour did a series of analysis shows that this was much more predictive than the previous tool in adults. So we have to see this tool to use in our children and to see if it's possible to validate it in other cohorts.
Okay, there is another question regarding the tool, whether it can be used in Henoch-Schönlein vasculitis with nephritis.
No, because this is an exclusion criteria from the group investigated and used for this study. They were primary IgA nephropathy. But we need to have it in children with Henoch-Schönlein purpura. This is why, since 3 years, we are gathering a large group of children and adults with IgA vasculitis nephritis, and Mark Haas has just finished the collaborative group of pathologist investigation looking at various pathology features. We had ready the clinical data, and so I hope that in 1 year results will be available. That will take time, but the hardest work, that means the pathology data, is just finished. And hopefully in a couple of years we will have available this toolkit for children with Henoch-Schönlein purpura nephritis.
Okay, perfect. So we should be a little bit patient. There are a lot of questions about the treatment. I'll try to group them. So some questions go about the steroid protocol. So what kind of steroid protocol do you recommend for IgA nephropathy?
For IgA nephropathy, there is a consensus that prolonged therapy are harmful, and the benefit are not evident in comparison to shorter periods. So I would go for 6 months therapy, either oral or methylprednisolone pulses, as recommended by studies in adults. Indeed, in pediatric cases, we had a study from Yoshikawa, and this was a rather ancient study. The steroids and azathioprine were used for 2 years, but this is indeed a too long time. You can gather adverse events much more frequently. So 6 months is a good moment, it's a good time in my opinion. Then if the child continue to have proteinuria which is not satisfactory, you can think about the possibility to have an additional treatment, maybe with mycophenolate or with other drug. We have a lot of hope in the new treatment, which are not so harmful as the old one. So we hope that will be used for long term instead of the classical corticosteroid we have now.
Okay, so there are also some questions about other immunosuppressive drugs, such as MMF or cyclophosphamide. Can you just comment when would you consider them in IgA nephropathy?
I was very impressed by the beautiful study from the Chinese doctor who was the first name a couple of years ago. They performed a study in adult IgA nephropathy with active disease, with a very clear pathology feature, endocapillary hypercellular crescents, mesenteric proliferation, and immediately shortly after the renal biopsy. So they were fresh and active cases. And they compared the effect of full doses of prednisone or half dose of prednisone and half dose of mycophenolate. And the results were the same. So in my opinion, mycophenolate can be a good chance to be used in association with steroids to reduce the dose of steroids as for the adults. So for the moment, the idea is to use the classical protocol for 6 months periods. But in my opinion, a possibility for the future is the association with mycophenolate with the possibility of sparing effect of steroids. But again, if the use of a target release formulation of budesonide will turn out to be successful, that would be the future, because we will avoid a lot of systemic exposure and so the side effects. Let's hope so.
Yeah,
so for the other drugs.
Yeah, sure. That was actually one of the questions, whether there is experience in children with budesonide and what to expect, whether it will come for this indication in children.
The trial in children is just in the pipeline, because there is the trial in adults, which is ongoing, and we have to wait for the results of the adult to apply for the EMA for children. But in the future, I think it will be available. The indications are perfect for children, because I'm strongly supporter of the involvement of the gut immunity in IgA nephropathy, and the study from Jean-Claude Davin, from a lot of pediatric nephrologists as well in the past, clearly showed that the gut-kidney axis is active in children. So if I have an hope, the hope is to use an early treatment in children, but this treatment should be used for rather a long time, more than 6 months, but should be not harmful. And this is the point. We have to be sure that the new treatments are not harmful. At the point, we will go further with the successful way of treatment these children.
Yeah, sure. So there are also several questions about novel therapies yeah, treatment which are used for other diseases. So several questions go about the use of rituximab in IgA nephropathy. So what do you think about that?
Yeah, everybody was a little bit deceived by the results of the trial. The trial with rituximab in adults some years ago was performed in adults with stable disease. And anyway, the results were absolutely negative. No effect on proteinuria, no effect on GFR decline, no effect on galactose deficient IgA1, almost nothing. At the end, it was supposed that the intestinal lymphocyte or plasmablast, which are devoted to the production of galactose deficient IgA1, are not a target for an anti-CD20. That's a possibility, because in ulcerative colitis, which is clearly an inflammatory bowel disease, rituximab is not useful. So one hypothesis is that the intestinal target is not the target for rituximab. But anyway, the other idea for rituximab was to reduce the production of IgG against IgA. So the autoantibody part of the disease, which I don't know, it's a pity that it was not of value. There are some reports of rituximab in IgA vasculitis, but they are not controlled, and it is so difficult to have a truly controlled trial in IgA vasculitis nephritis, because the disease is different and is shown by the German study group. It depends when the biopsy is performed, and which is the phase of true reactivity. So there are some positive reports of rituximab in IgA vasculitis nephritis, but they are absolutely uncontrolled.
Okay. So this is, I think, very good. You answered a lot of questions about rituximab. There were a lot. There are some questions about like all the treatments, like fish oil. Is there still place for that?
Well, fish oil was, again, was a good idea, but unfortunately the results were rather inconclusive. Ron Hogg performed a very good study, performed several collateral investigations, showing that maybe some subset of fish oil can be useful or not. But at the end of the story, is not harmful at all, but the benefits are rather inconsistent.
Okay, so there is an interesting question whether there can be a role for this novel type of drugs, SGLT2 inhibitors in IgA nephropathy.
Which one?
From this novel drugs from sodium glucose co-transporter 2, you know,
Yeah, sure.
Yeah.
This is the most interesting idea at the moment. Well,
yes,
the reports at the American Society, there was a slide showing that the sub-analysis of IgA nephropathy patients showed a benefit of SGLT2 inhibitors, specifically in IgA nephropathy. This is a tricky information because the study was a large study, a beautiful study, but not focused on IgA nephropathy. And to select a group without any control and saying that this group was of benefit, it's like the use of renin-angiotensin system inhibitors at the beginning if you had taken off the part, a subset of patients with a particular disease. So the idea is good. There is no particular reason why these drugs should be useful in IgA nephropathy more than in other diseases. So I think that the reason for the use, because this is a very important drug, obviously, but the mechanisms are not particularly, in my opinion, are not particularly related to the pathogenetic event of IgA nephropathy. So the benefits may be huge, but may be similar to the benefits which will probably be obtained in other glomerular diseases.
Okay, so several people are asking about the indication for kidney biopsy in Schönle vasculitis.
Yeah, this is a point. You're right, because you can say, well, make a renal biopsy to everybody. But anyway, this is not correct because a lot of children show a prompt improvement, and the renal biopsy is always an invasive tool. So, in my opinion, the best idea is to go patient by patient and to see if the patient after a few days in the first week shows features which are consistent with something more than a simple acute nephritic syndrome, a renal biopsy can be useful. The other point is to go for methylprednisolone pulses or corticosteroid therapy and see the results and use renal biopsy in a second moment. But this is impossible to say do that because this is completely handmade, and so it's impossible to give an advice in this way. So the only advice I can see is go case by case, see in the first week and perform renal biopsy, and you have something hard in the hand. And I hope that in the next future that will be useful to predict the progression of the individual case, and so to use or not potentially toxic drug.
Okay. The questions are still coming. I think we can answer a few of them. Again, I tried to group. So several people are asking about treatment of therapy-resistant IgA nephropathy or Schönle nephritis. There are children with therapy-resistant nephrotic syndrome, children with progressive kidney failure. What would you recommend in these kids?
Yeah, there are a few of them, but there are, and again you go case by case because the literature doesn't offer a lot. I think that mycophenolate is the less toxic, and then also cyclosporine A, because we have a lot of experience in both drugs. So using a drug which we know very well for transplanted kidney, transplanted children, like mycophenolate and cyclosporine A, is a good advice in my opinion. In some cases, there are some results, but these cases, there are some very difficult cases, some cases in which you can see a progression in spite of any kind of treatment, and I suspect that the genetic conditioning in this case is the most relevant factor. But anyway, in face of the child, mycophenolate and cyclosporin cyclosporin A can be an option. I mean, cyclophosphamide is useful only when there are some features of a particularly aggressive disease and an acute disease. For a short time may be an option, but I'm always afraid about these drugs, so I would limit and go for safer drugs if possible.
Okay, I agree. Also, I got some very severe IgA nephropathy progressive in remission, combining pulses, solimedrol, methylprednisolone with MMF. You should have some patience with these kids, I think, but
Yep.
sometimes they would reach remission when you just continue with MMF and some maybe lower dose steroids for some time and then taper. Okay, so there is also a question about the recurrence of from IgA nephropathy after transplantation. Can you comment on that? How frequently it occurs? What to do with that?
Again, unfortunately, are the worst cases, those who reach end-stage renal disease in the pediatric age or in the young age, are often those who have a recurrence. And it's in a minority, and in general, the recurrence appears in the first after the second year, after 2 years of transplantation. In general, it's not so severe like the first disease, probably because of the immunosuppression on transplanted kidney. But the study didn't find any particular effect on mycophenolate or other drugs in the recurrence, in preventing the renal damage.
There are also some questions about the recurrence of the disease in the native kidneys. When the child gets into remission and then after some time would recur, what do you recommend in these cases?
Yeah, well, I suggest to repeat renal biopsy, because if there is a recurrence after a remission, probably there is a new series of pathogenetic events, and you have to know which is the chronic lesions which are in the background and the extent of new lesions which are curable. So don't be afraid of a second renal biopsy. It's useful for the child.
Okay. Maybe last two questions and then we will stop because we are getting a little bit out of schedule. So there is a question about the role of hematuria as a risk factor in the evolution of IgA.
That's a good question. I'm sorry, because for a sake of time, it's impossible to cover all the aspects. I strongly in favor of the results reported by the Spanish group and by the Mayo Clinic group. I mean, hematuria is not only a feature of IgA nephropathy and persistent henochonic purpura nephritis, but is something which is related to the activity. So if you have the possibility to follow the urinary sediment and the extent of microscopic hematuria, having a persistent microscopic hematuria higher than 25 red blood cell per high power microscopic field, for instance, is something which has to be considered.
Okay. So maybe to finish, well, there are some questions about intestine, the role of intestine. So one question about the link between Crohn and IgA nephropathy, and another one a little bit in the same direction about the gluten-free diet, whether it's recommended in IgA nephropathy.
Yeah, there are several connections between the gut and IgA nephropathy, and particularly between celiac disease, but also the other intestinal bowel inflammatory disorders. There were some very extensive, large cohort studies on thousands of patients with some Crohn's disease or other inflammatory bowel diseases, and showing that the association is clear from a statistical point of view. But that does not mean that in any case you have a strict association one-to-one. That means the pathogenetic events are similar, the basis is similar, and that can be useful if you think about new treatment. Anyway, the association is there from the genetic point of view and also from the epidemiological association. The diet, the modification of diet and microbiome is against a future. Maybe everything is in the microbiome, is the intestinal communities of germs which are highly modified in different situations, and in intestinal disease they are very different from normal subjects. This area was investigated in IgA nephropathy, but the study also at the beginning. Our old study on the effect of gluten-free diet were confirmed by the study by Renato Monteiro's group in Paris. But again, these data are mostly based on investigations in animals or in vitro investigations, and the data, no clinical trials have been done, because a trial is difficult, is complicated, means a huge number of patients, and so at the moment there is no clear indication, but in cases where the intestinal symptoms are evident, if there is evidence of some intestinal chronic disturbances, even without a complete diagnosis of celiac disease, you can try, in my opinion, a gluten-free diet.
Okay, thank you, Rosanna. I think the very last question, because I think it's also an important one, because you broke the record in number of questions and the persistent, and I see how many people are still listening. So I think, so thank you very much. And by the way, a lot of people thank you for the excellent presentation. So the very last question, do you recommend the combination of ACE inhibitors and ARP in IgA nephropathy?
No, it's another point of discussion, because the KDIGO does not support this association. They are very strong on it. They say or one or the other. Well, in opinion of many other authors, this is not so strict. But anyway, I report the KDIGO point of view.
Okay, I think this was a short answer, and I think here we have to stop. And I really thank you for this excellent lecture, and I thank everybody for staying online so long. I think we all learned really a lot, and I apologize for those whose questions are not answered. It was not possible, otherwise we will stay until very late in the evening. So thank you very much, Rosanna, and my opinion is that we should invite you to give another lecture, and so that all questions regarding this important disease can be answered. Thank you very much, and have a good day or good evening, everybody. Bye-bye.
Thank you. Bye.